And thinking about a lot of what I do these days with patients, I work with pregnant women with substance use disorders as well as in our IOP program. And oftentimes we're really helping people with advocacy, whether that's advocacy in their own community, in their family, with child protective services, with legal entities. And one of the things that makes advocacy challenging, especially self-advocacy, if people are trying to advocate for themselves, is when people have had a trauma history. Because by definition, people often experience dysregulation when they have a trauma history. So that's what I was going to talk a little bit about today. And one of the cases is a specific example of that. And then I think we have another case that is tied in with that as well, because I reviewed that case. So we'll talk about just what is advocacy and when do our patients need help with advocacy skills, what gets in the way of self-advocacy specifically in the context of when patients have experienced trauma. And then like the skill building that's really needed for helping people with advocacy skills. And those are usually communication skills, but also to effectively communicate, we need to be able to regulate our emotions, which is not always easy in very highly charged situations or situations that have been re-traumatizing. And so interpersonal effectiveness, I'll go over interpersonal effectiveness in the context of DBT therapy. So interpersonal effectiveness skills that DBT highlights are really, really helpful. And then the idea of practicing. So it's funny, I was a little bit late. I was just meeting with a client where we were talking about her having a conversation with her boss and how to advocate for herself for, a promotion and how to do that and what gets in the way of being calm and what gets in the way of her really being able to get her point across clearly. So practicing that, whether it's role playing or making sure people are kind of writing it out first, there are all kinds of ways to practice that. So just a little bit of a definition of advocacy. Advocacy is any action that speaks in favor of, recommends, argues for a cause, supports or defends, or pleads on the behalf of others. So really helping people put voice to things that often are very jumbled up for them because it's been so emotionally charged is often a place where we start with our own advocacy on the behalf of others. And then why it's important is oftentimes when people are not able to advocate for themselves, they get run over, right? That's what they talk about. Like people run right over me. They use me as a doormat. And so they get sometimes re-traumatized in that context or not able to get their needs met. It's a way to offer support and inclusion and also to create a more equitable power dynamics, because oftentimes people feel very disempowered in the settings in which they struggle to self-advocate and need our advocacy. So just some of the goals, which is, you guys know this stuff, is to empower people who don't feel that they have a voice, to offer support through advocacy, to assert a position on behalf of someone, so that they can feel represented, so that they can feel like someone's really on their side and understands their perspective and their experience. And also to teach them how to advocate for themselves, to enable them to really engage in self-advocacy. And this is all built on a relationship of trust. So what are the different contexts? Certainly in people's own families, it can be hard to advocate for themselves. So an adult child with a parent or a partner with another partner or grandparents, certainly in family settings where there's power dynamics that are unequal in the legal setting. So some criminal justice setting, people often need advocacy when they see things that aren't right, but they have trouble really pointing those out to others who they're working with, like lawyers or prosecuting attorneys. It's very intimidating. Child protective services. So sometimes patients talk about feeling either unheard or discriminated against. And that's, an experience where we can help with advocacy. Any kind of interpersonal relationship, really. Oftentimes, if there's unequal power dynamic, it's hard for people to feel that they have a voice and feel empowered to use it. And also, I was thinking about really the internal process that people experience. This is one of the reasons that people struggle with advocacy, is they often have messages that they are telling themselves inside your head, like, this is never going to work, you can't do this, you're stupid, nobody's going to listen to you, those kinds of messages. And so sometimes we need to work with people to instill some hope that they can, and that things do get better in order for them to feel like they can take that step to advocate for themselves. Any other examples that people can think of where clients need advocacy?
I'll monitor the chat for you. Nothing has come in yet, and everyone's welcome to chime in as well. Oh, Richard Jackson, Jack Diamond says care.
Yeah, that was going to be my other suggestion too. In the healthcare arena, sometimes others might just write something off to their substance use disorder and not look underneath at other signs and symptoms that are going on.
Absolutely. That's a great example. Yeah, so we often we have clients that we work with that have really complex medical conditions that, due to healthcare literacy or the fact that nobody's explained it in a way that they can understand, sometimes they need advocacy, both understanding the care that's being recommended, understanding what the disorder is and the implications on their functioning, and even understanding what treatment's being recommended, because that's not always clear for folks. Okay. So the impact of trauma. So when we think about what it takes to advocate for yourself, when you've experienced trauma and all the things that you guys know that go along with trauma, you can see why this makes self-advocacy very, very difficult. So typically trauma survivors of any kind of trauma have difficulty recognizing their own needs and sometimes accepting that they have needs and that they deserve, like their needs deserve to be met. So that's, an experience of people with complex PTSD often have trouble with those. We know that fight, flight, and freeze response is activated. The limbic system is very active. There's emotional reactivity and hyperarousal. If you are trying to be calm and advocate for yourself, this gets in the way of being able to do that effectively. And most times the response or that reactivity looks like avoidance. So that would be the flight, numbing, which is the freeze, or lashing out, which is the fight. And so trying to calm those kinds of, that kind of reactivity is essential for teaching people how to engage in self-advocacy. There's often a lot of cognitive errors, including excessive guilt, blaming themselves, self-defeating behaviors. Things are never going to be any different, so why should I try? And that can get in the way. I think there's things happening in the chat. Mitra, I don't know if I need to address any of those.
Oh, no, you're good. Thank you.
Okay. Okay. And then there's been some research specifically about the negative impact of trauma on self-advocacy, and that's one of the references that I have. So one adaptation to trauma is often to try and be invisible, and not call attention to yourself. And when you advocate for yourself, you're doing the opposite. So it feels like it runs contrary to some of the adaptive coping strategies that people with complex trauma have. And so again, this is just sort of a visual of how having a history of trauma make learning advocacy skills challenging. People have skills deficits, including things like de-escalation skills, that lack of self-efficacy, lack of confidence. Feeling undeserving is certainly something that can get in the way. High emotional states and reactivity, and the need for practice. And sometimes feel like, oh, other people can do this so easily and it doesn't come easily to me, and they're not used to having the experience of like, when I practice something, I can get better at it, even if in the beginning it feels like I'm really, really bad at this. And so that's part of gaining that self-efficacy, is like with practice over time, I can actually do this. And just a reminder, when we think about the context of child protective services and patients, us helping them with advocacy and engaging in self-advocacy, it is particularly difficult to engage in self-advocacy when you are actively in a state of trauma. So when you have your child removed from your custody, that is a traumatizing event. And so we're expecting people to be like calm and focused and be able to communicate their needs when they are in the midst of, a traumatizing event. That's a lot to ask for and a lot to do. So moving on to kind of the steps of teaching advocacy and self-advocacy, preparing people for the context, whether they're going to go have a conversation with their boss or go have a conversation with their mother, or go have a conversation in court with in front of multiple people, including judges and lawyers. That's going to be important to talking through with people what that's going to be like for them, what kind of emotions are going to come up with them, and what kind of skills they're really going to need to engage. And starting with effective communication, I like the phrase like talking so that other people will listen. So if I'm yelling and cursing, nobody's really going to want to listen to me. But oftentimes the clients that we work with don't have a lot of modeling. They have not had effective communication modeled for them and their families, or in whatever context they currently live in. And so those skills and the phrase like talking away so that someone else is going to want to listen to you, and they're like, oh, like what would that sound like? And then they can reflect on their own experience of like, well, how do other people talk so that I want to listen to them? Learning about verbal versus nonverbal communication. We communicate all kinds of things before we ever open our mouths. And so that's just really about increasing self-awareness of what our body looks like, what our facial expressions look like. That is part of our communication. And then different forms of communication. Some people feel much more effective communicating in writing. They feel like they can take the time that they need. They feel like they can articulate their thoughts better. Other people feel like they can, communicate better with the spoken word. And so this is something for people to explore and practice and figure out what works better for them. And the skills that we'll talk about are communication skills, emotion regulation skills, interpersonal effectiveness skills. And again, I'll borrow those from DBT, those last two, and then de-escalation skills. So the idea that language, we can use language to escalate situations, like when we curse and accuse people of things and use you statements, versus de-escalating language, which are usually validating statements, I statements, speaking from our own experience, listening, doing active listening, and really holding personal space if you're meeting with someone and communicating with someone in person. So just a little bit of review of emotion regulation skills that can be really helpful when we help people with advocacy and self-advocacy. So this is sort of before the communication happens. These things are very helpful to learn. So the first one is, emotions, identifying our emotions, being able to observe our emotions without judgment, being able to describe what we're feeling in the moment. These are all things that can help ground people into being able to respond instead of react in a given situation. And this just takes practice. So doing this with clients and having a practice, even when we're in session with them, you can do this in groups. It's a great group activity of like, what is anybody feeling right now? What is that connected to? What are the judgments that you sometimes have come into your head about what you are feeling? And just sort of practice that awareness. Decreasing emotional suffering is another kind of DBT acceptance skill, which is partly observing your emotion, remembering you are not your emotions. And that can be very helpful when people get completely dysregulated, overwhelmed, and feel like I'm going to feel like this forever. This is never going to go away. And my emotion is truth. So really creating a little bit of distance from an individual and their emotions, understanding it as an internal process, but not a defining piece of who they are as in self, as fundamentally as a person. We all have emotions, and that does not necessarily define who we are. And then practicing acceptance. So accepting that, I have had these traumatic things happen to me in my life. I'm going to try and live my life differently moving forward, but I need to sort of accept that they have happened versus getting stuck in anger, resentment, or hopelessness that some people have in response to those traumatic events. Decreasing unwanted emotions. This is an action, a DBT action skill. So changing beliefs and assumptions. So we're all familiar with that from CBT and DBT. Opposite action is kind of a DBT concept where you feel like curling up in a ball and laying in bed. And so you actually are going to engage in a behavior that is opposite of that. So going out, pushing through that and doing the opposite of that. So leaving your house and doing something outside of your house, let's just say. And then active problem solving. So instead of, that's really solution focused. So instead of getting stuck in a victim role or again, a role of hopelessness, like there's nothing I can do, I can't change the system, what's the point? Really engaging in active problem solving about what people can have an impact on. And then decreasing emotional vulnerability, which is all about building a life worth living and accumulating positive emotions. So engaging in activities that kind of result in positive emotions and mastery, and that builds self-efficacy. Coping ahead, so thinking about, I'm going to have to go see, my mother-in-law later. This is going to be very challenging for me. What can I put in place in advance of that meeting or that dinner or that, thing that I'm going to go do with her, that's going to allow me to be as centered and grounded as possible because I know it's going to be a challenging event. And then taking care of your mind by taking care of your body. So not underestimating how important sleep and eating as healthy as possible is. So this is kind of a CBT diagram. So the idea of teaching, I use this visual to teach people about emotion. So you have an emotion and every emotion has a corresponding physiological experience. So where do you feel your anger? You feel it in your chest, you feel it in your stomach. We kind of go over that. And what do you do when you feel that emotion? So when you are angry, what do you typically do? And people can identify that. And when you are angry, what are the thoughts that you're usually thinking? Like, that guy's a jerk, I don't deserve this, different kinds of cognitions that are associated with the emotion. And then also teaching people about being aware not only of their own internal emotions, but the emotions that other people may be experiencing. And so that helps people with effective communication to gauge, they just don't sort of plow ahead with their own agenda. They take stock along the way of people's reactions, responses to what they're saying, and then can adjust as needed with, say, de-escalation if things are beginning to escalate. So I'm not going to go over this. It's kind of small, but it'll be on the slides that get distributed. So this was just a really nice visual that I found of some emotion regulation skills. It's even, you can like print it out and give it to clients. It's just a really nice one-page summary of different kinds of emotion regulation skills. And then moving on to interpersonal effectiveness. So again, anybody's familiar with DBT, the acronym Dear Man Give Fast, some people think is kind of a strange acronym, but this is the acronym for the different kinds of interpersonal effectiveness. And the different kinds are based on what the goal is. So sometimes the goal is preserving the relationship. Sometimes the goal is achieving a certain outcome. And so the different skills are used depending on the different goal. So the foundational one is Dear Man. So you're going to describe the situation. You're going to express how you feel about it. You're going to assert what it is you would like to see, and then reinforce that while being mindful and appearing confident and negotiating. And you can imagine in any kind of stressful situation, this takes practice. This absolutely takes practice. This takes practice for like people who have not experienced significant trauma. And so for anyone who's had significant trauma in their lives, this takes practice. And then the Give Fast really targeted to other kinds of goals. So when we think about, I'm going to have this communication, I want to be effective. What is my goal? Is the goal that I'm going to get what I want? So Dear Man is really the skill for getting what you want. And if the goal is, I want to preserve the relationship, you do Dear Man plus Give Fast. I mean, plus Give, which is you want to validate and express support. And then if it's really about preserving self-respect, you do the full Dear Man, Give Fast. So we'll go over these a little bit more in detail. So again, these are fairly self-explanatory, but it's nice to have a little bit of description of how to engage in these. So when you describe, use clear and concrete terms, and say, could we maybe do this versus I want you to do this. So, using language that is not going to steamroll other people. And the appearance is appearing confident. So that's about all the nonverbal stuff. So you guys can, again, you're going to get these in the slides. And the Give is really about communicating caring, because that's the preserving the relationship skill. And so accepting other people's responses, not getting defensive in response to if somebody else is struggling with what you're trying to communicate to them, showing interest and listening, validating their experience or what they're sharing that they feel, and then trying to be sort of relaxed and easygoing. Excuse me. And then the Fast is really when the focus is on preserving self-respect. And the Fast stands for fair apologies, as in no apologies, or apologizing only when necessary, and sticking to your own values and being truthful. So not exaggerating. That's oftentimes when people are trying to get their point across. Sometimes we exaggerate and sticking to the facts. And so back to practice. So communication is a skill that improves with self-regulation, and self-regulation takes practice in and of itself. Even if you're not even trying to communicate anything, just practicing self-regulation. Communication skills are really essential to effective advocacy. And you can practice in groups. So the group setting is a great time to role play. You can practice in individual and role play. I'm a big fan of role play because most people learn fairly effectively through experiential learning versus just like talking about it. And so the experiential learning can be really, really important, both physiologically to tolerate what comes up for them, because what comes up for them role playing with me is going to be very, very small in terms of reactivity versus what's going to come up in the real situation. And so getting them to tolerate even the small reactivity that may come up when practicing with me is a good first step. And then there's really some research around self-advocacy being a form of trauma healing and a form of self-care. So the idea when you've had complex trauma of finding your own voice is very therapeutic, figuring out how to set healthy boundaries, feeling empowered to make decisions about your own life, finding support for yourself, knowing what your rights and responsibilities are, where they begin, where they end, what they are, that they should be respected, and reaching out to others to ask for advocacy, and then learning that self-advocacy, problem solving, not accepting unacceptable behavior, and being able to identify what is unacceptable behavior, and also owning your own actions and words and deciding what is suitable for you and going to get it. So this is a quote from one of the researchers about redemptive storytelling, which can translate into people getting ready for self-advocacy. And it reads, among the proposed advantages of redemptive storytelling are its psychological benefits, potential to empower self and others, promotion of meaning-making, mission, and communal solidarity, and the larger social political changes that can emerge from giving voice to silenced experiences. So again, usually when people have histories of trauma, they have been silenced in some way, especially if they were children when the traumatic events occurred and they were told not to talk about it. And so empowering people to have a voice and engage in self-advocacy can really be helpful. And that's just a final quote. And then there's some resources and references.
Thank you so much, Laura, as always, for a wonderful presentation. So much great information in there, and I'll be sure to include it in the recap email so everyone can have a copy. But any questions for Laura, comments, feel free to unmute, or you can also chat in and I can read it out loud. And we always like to emphasize that it's a safe space, so everyone is welcome to open up or comment on anything. Okay, and then if you do think of any questions, you're welcome to chat it in. We still have about half the session left. And Laura, I know you have a case that might tie well into your presentation, but I didn't know if you wanted to do your case and then we can have Quentin go after you present, but how does
Yeah,
that?
I think like Quentin can go if he wants to go first.
Yeah, Quentin, how do you feel about that? I know maybe it's your first ECHO presentation, right? So no pressure at all. If you'd like to see Laura present hers first, you're welcome to do that as well. But yeah.
No, I can go ahead and do it. That's fine.
Awesome. Sounds good. Let's see. And thank you so much for presenting a case. We're really excited about it. So, but yeah, essentially you can just tell me when to scroll up or down. I'm here for you with all the tech stuff. So that's what I'm here for. But I'll just let you go ahead, present it, and then we can get into any Q&A or discussion that you have regarding your case. So I'll turn things over to you.
Sure. Thank you. So I'm going to try to make this as quick as possible. So firstly, I work through comprehensive addiction treatment services and family medicine at WVU Medicine in Jefferson County. So I do Suboxone programs. So I will be presenting about one of my clients that I see regularly. 43-year-old, thank you for enlarging that. 43-year-old female, diagnosed with opioid use disorder, severe dependence, cannabis use disorder, GAD, and panic disorder. Referred to our MAP program approximately 3 years ago. She attends weekly group therapy and is usually seen frequently for individual therapy. As of recently, she endorses increased anxiety and more panic attacks related to recent grief, which we are addressing regularly in therapy. She's had multiple family deaths over the past several months, and we are working on regulating her emotions and just ventilating as much as she sees fit. She is followed externally with a psychiatrist in the area who prescribes her Paxil and propranolol. These typically control her symptoms, but in times when she feels that she is more anxious, she tends to reach out and wants individual therapy. She's really good at advocating for herself, and she when she really needs the therapy. Can you scroll down for me, please? So with the grief and the related trauma through the family deaths over the past several months, there is also another factor that's causing a little bit more anxiety, and that is unfortunately me leaving WVU Medicine. So I am wondering if anyone has suggestions or thoughts as to how to wrap up a client who I've been seeing for 2.5 years to 3 years, who has done reported multiple traumatic events to me, processed a lot, we've gone through a lot. There's been a lot of challenges, multiple modalities used, a lot of trust built and a lot of rapport built. So if anybody would have any suggestions or recommendations as to how to wrap up the process and appropriately transfer or refer internally, that would be fantastic. I'm aware that the heightened stress and the changes in the clinician could potentially impact her recovery in a negative manner. I do think that she has a lot, again, she has a lot of advocacy and she wants to try to maybe start coming off of Suboxone. So we are talking about that in our sessions, although right now might not be the greatest time to do that because of the stress.
Well, first and foremost, huge shout out to you. You did awesome. Thank you again for submitting the case. Really interesting question you have as well. I don't know that we've ever really had a discussion in depth about that. So I'm really curious to see what folks have to say about that. It's a great question. But yeah, I'll do a long echo pause. I'll give anyone a chance to unmute, maybe have some advice or recommendations for Quentin.
Hey, this is Nancy Morgan down in Grafton, West Virginia. Can you guys hear me?
Yes.
Yes.
Okay. So here's the thing. Make sure the patient is really, really ready. But hang on to her as long as you feel like you need to until you know for sure that she's ready to go. And let her make that decision. That way you guys are working collaboratively together. And she can say, hey, I'm ready, or hey, I'm not ready, that kind of thing. And years ago, I lived in Iowa with SUD counselor, and I had a guy who I'd worked with him for a year, and I told him, I said, you tell me when you're ready, and he told me when he was ready. So to me, I think that's the most important thing, is just let the patient decide. And if it feels like you don't want to go on and on and on with her, then you can, have that conversation with her and just say, hey, at a certain point, you're going to have to figure out a way to see somebody else. So that's my advice. Just let her be the judge of it, because who knows the patient better than the patient, right? So that's my advice.
Thank you so much, Nancy. And Dr. Gorby also had a chat in saying a warm handoff, personally introduce her to the new therapist.
Yeah, that's a good idea too. Yeah, for sure.
Thank you both for those recommendations.
Any other comments or recommendations from the group?
So Quentin, you're bringing up termination issues, and one of the things that I always think about is we don't always have the opportunity to do good termination because patients don't stay to the end of our relationship with them, whether because they leave prematurely or we leave prematurely. And so this is really, in some ways, like a really nice opportunity to do a full review of all the progress you guys have made together, and you communicating to her, and there's more to be done, and it doesn't have to be done with me. So almost like supporting her and like, I know you can do this work. We'll look at what we've done, and then the direction in which you might recommend she go, and that because of the progress you guys have made together, that she can do it with someone else also, like she's healthy enough to do it with someone else, which it sounds like that would be a true statement for you. So sort of empowering her to work with another person.
Very much so. That's what we actually discussed in our last session. We talked about how maybe a different perspective for a different clinician who might offer different advice than I do might actually be beneficial.
And I don't know if you're aware, WVU medicine at Chestnut Ridge Center, we are conducting a study where we actually help people discontinue if they want to from buprenorphine. And it's actually a fairly supportive study. So they get a lot of support from medical clinicians, as well as the research assistants and the research coordinator. There's no therapy involved, so it sounds like she would really benefit from continued therapy, but it is really a safety net for people who want to see if they can discontinue, because they get followed for 2 years. And if it doesn't work, they don't have to, continue to discontinue. So it's something to consider if you want more information about that.
Awesome. Yeah, I would love that if you could send it to me. Thank you for the advice.
Thank you all so much for chiming in, and thank you, Quentin, for the excellent case. Did you have any other comments or questions about your case that you wanted addressed with the group?
I think I'm good. Thank you guys. I appreciate it.
Thank you.
From our side, it's been hard because Quentin's actually moving on, but it's a great, we've been lucky to have somebody that stable. And I think that's one of the challenges in medicine and probably in therapy a lot more. Like Laura said, it's not, people aren't there forever. And so I think for patients, doing that transition is real important.
Absolutely. Thank you, Dr. Baltiera. Any other comments before we go to the next case?
Oh, I just wanted to say that's an excellent resource that they have at WVU, to have a group that provides people getting off of buprenorphine, and having that resource is really essential, should be everywhere. But you could make it part of any program, but that's great that they've got that lined up. So that's good. Wanted to throw that in there.
Absolutely. Thanks so much, Chris. I totally agree with you.
Yeah, it's actually a study. And so it's a study where we're looking at, it's a NIDA funded study where we're looking at who does well trying to discontinue, under what circumstances, using what kind of medication, like long-acting injectable versus oral. So it will be interesting. We will report to this group once we have the results. And Tony is part of that study, and Dr. Husted, and a couple people on here.
Yeah, I would love to see the results when you guys get those. That would be great, sharing it with the group. All right. If there are no further questions about this case, we can move on to Laura's case. Laura, I will share screen for you, and same thing, just let me know if you'd like me to scroll up or down, and let me zoom in here for you. All right, I'll turn it to you. Thank you.
Thanks. So this case was actually submitted by Anna Butcher, who is our urgent family care coordinator and does a lot of advocacy with Child Protective Services and the legal system. So she was unable to attend, so I'm going to present this on her behalf. But the patient has a substance use disorder and was referred to her because she had significant setbacks with CPS and was really not feeling heard or listened to, and was super frustrated. And there was a breakdown in communication with her caseworker. And so Anna was called in to help with some advocacy. She has remained stable in the COPE program for 8 months and attends weekly therapy. She has 1 child currently in custody with CPS. And the patient has significant trauma, and then as a result struggles with emotion regulation in her communication with CPS and other people, and so that she was running into some trouble communicating. And so they discussed how they were coping with the lack of visitation, so they weren't sort of moving along in the process as quickly as they wanted to. And again, we're feeling like they did not have a voice in their own MDT meetings with CPS and the other members of that team. Anna felt that the patient was quick to anger, probably related to her trauma, and also felt rejection and judgment, and that led to them being aggressive and defensive, creating really a hostile environment in the MDT meetings. and negatively impacting their relationship with the CPS worker and their lawyer, actually. And so Anna has worked with her to talk about ways to, well, she's talked with her addressing her concerns, and then talked with her about various approaches to engage in more effective communication. And one of the things that they have opted for, and Anna helps her craft some of these emails. So she's communicating via email to her worker and her lawyer, and she feels like she can be much more professional. She can regulate her emotions better because she has more time to craft what she wants to say, and that has gone better. So using that email writing gives them more time to think through their words, and they felt like that this has really helped a great deal. The patient is currently working on rebuilding their relationship with the CPS worker, and feeling like there's some progress there, although it's slow. They feel supported and have new skills to help them navigate interactions with their lawyer. And I think what has happened is they feel heard and supported by Anna. And then this has allowed them to be more regulated. They feel like someone is listening to them and validating their experience. And that way they get to de-escalate themselves. So they're currently on Sublocade. And so the questions that Anna had for this group are, what are some ways providers can support patients' sobriety when they're under this much stress in the context of child removal and CPS? And in what ways can CPS and treatment programs work together to ensure patients with substance use disorders and those who struggle with emotion regulation are treated appropriately to reduce potential relapses? And how can we create a better understanding of the substance use disorder diagnosis and the prevalence of dual diagnosis, and especially complex trauma? So I will throw those questions out to the group.
Awesome. Thank you for presenting the case, Laura, and I'll thank Anna as well via email for submitting the case. But yeah, I'm happy to share screen again if anyone needs to refer back to the case or the questions. But with initial thought, any responses, feedback, recommendations from the group?
I know what's really helped our patients who are in a similar position is to really partner with the patient. And what we actually do is go overboard in partnering in terms of, I know because a lot of patients feel like CPS is against them when that may or may not necessarily be the case. And so what we do is just let them know we're on your side, make it very clear about what is actually communicated to CPS with their permission, have them look at any letter, any correspondence, and then actually ask them, well, what do you think is going on and how can we help partner with you to make your case known? And that's helped us out a lot. Because a lot of times when our clients have emotional dysregulation, they have no clue they do, right? And it can be pretty hard and pretty tough for them to see. They just feel as if everyone's against them. So for us, I mean, for me particularly, it's been very helpful to partner with them, put them first, and also be aware of my own, reactions. Because my personality type, people with more so cluster B and personality, explosive personalities, I tend to be a little, it actually irritates me as a provider, right? And so I have to be very aware of that and aware of my bias and how I feel, and then regulate that myself. And just really put the person first. So being very clear about what is communicated, partnering with them, and what we've actually helped is actually help them communicate with lawyers as well with their permission. And I found that helpful.
Thank you so much, Dr. Vo. Any other comments from the group? I'm happy to pull up the questions again as well.
Laura I'm sorry, and the CPS ECHO program that I know that you're highly involved in, have any of these topics about dual diagnosis and expression of patients or clients with historic trauma been talked to with the CPS workers or presented as a didactic?
Yes, we've had a variety of topics, and certainly trauma comes up on a regular basis. One of one of the things that Anna has been able to accomplish is being a presence at MDT meetings. So she goes to the MDT meetings, and she got some pushback in some counties saying basically we don't want you here in the beginning, and that has greatly improved, which is wonderful because she can model effective communication skills, and she can validate the client while validating CPS. So she can really do a lot in a lot of those meetings. And she also gets to see, firsthand how the client is being treated in those meetings and the personalities involved, because sometimes there can be some strong feelings among the providers or lawyers in those meetings as well. And then she can help the patient navigate those. So it's really, I know that she does that as part of her advocacy on really an individual level with the CPS worker to let them know this individual has a history of trauma, and what happens when that happens is that they have trouble with dysregulation, and that comes across as them cursing at you when in fact this is really about their own trauma. So, helping the CPS folks maybe not personalize it. Not that anybody deserves to be cursed at, but like understanding the context in which that is happening.
That's great. She does a fantastic job. She's a real asset.
And the other piece of that is, as Dr. Bowe was saying, like, demonizing CPS will not help anybody. It will not help the client. It will not help us advocate for the client. And it feels terrible to CPS who are trying to keep children safe. And it's a system that isn't functioning maybe at its best, which is not the individual CPS worker's fault typically. Kind of helping everybody take a step back and look at the bigger picture. One of the things we've been able to do is engage people at higher levels at DHHR to talk about, some of these issues and problems as part of our, kind of strategic plan in terms of community engagement and advocacy. So it's a slow process, but I feel like we've made some inroads, and really Anna has made the biggest impact that I think trickles down very directly to patients. And Dr. Husted, I know, has also done a lot of advocacy as well.
That's great. Thank you so much, Laura. And we got a couple chats in as well. Dr. Gorby was mentioning meditation and mindfulness could help. Quentin also mentioned saying, I'm thinking of other modalities such as EMDR to potentially aid in desensitizing triggers when communicating and advocating for self. That is also a great one, Quentin.
Yes. So certainly trauma treatment in multiple forms can always be helpful. And I'm a big proponent of mindfulness as well.
That's helpful for everyone. I definitely could utilize meditation and mindfulness in my daily life. Any other comments from the group? And Laura, did you want to address any other questions from Anna's case, or do you think that was pretty much everything? I can pull up the case again as well.
Yeah, I have it pulled up. Oh, the other thing that just to highlight is that I have personally experienced that CPS can be much more responsive when communicating via email versus trying to call them on the phone. And for this particular patient, they found that form of communication was actually a form of communication in which they could be more effective. So the combination of that was actually really helpful to hear, that's something we can encourage, clients to do, is maybe instead of calling when you're really, really pissed off, maybe crafting a thoughtful email. I mean, this is good advice for all of us, right? That this is a skill that, can be developed by clients, is helping them with writing as an effective form of communication.
That's a great point. Anyone else with comments or thoughts? We have about 7 minutes left. I don't want to rush the session in case there are other items to discuss. So I'll do the long echo pause again. Alrighty, well, thank you all so much, Laura, for the presentation, and both Laura and Quentin again for the case presentations. We really appreciate your time and all of your time as well for chiming in. It's because of you guys that we can do these sessions, so we really appreciate each and every one of you. My only announcement for today is that the next session will be on February 12th, and we're going to have Dr. Cynthia Pursley join us, and she'll be discussing the new department